Good afternoon, all. Today I'll be talking about pediatric trauma. I thank Dr. Rekha and the other co-instructors for having me in here today. So I will be talking about an individualized approach to trauma. Ocular trauma, as you know, is an important cause of eye morbidity and a leading cause of non-congenital monoocular blindness in children. Eye trauma accounts about 7% of body injuries and about 10 to 15% of all eye diseases. And less than 3 years, there could be fingernail of parents, caregivers, or siblings which are involved in all the children, sharp objects, toys, deep branches, pencils, sports, stones, and a lot of variety of other things can cause a trauma. So this is the PET's terminology classification: closed globe and open globe, contusion and lamellar laceration, rupture and laceration, penetrating, perforating, and IOFB, just for your remembering that. And then we will come into the epidemiology of pediatric trauma in central India. This is a large study in which you can see that about a large number of injuries were caused by organic matter, about 30% of them. The other causes of injuries could be metals, stones, alkalis, glass, fingernail, etc. Rupture was very uncommon, basically because children's sclera is very thick, and laceration is quite common, with penetration with a sharp object or perforation. Retained intraocular foreign bodies are less common, and closed globe injuries with blunt trauma is also quite likely. Evaluation of patient is a very, very important thing. These are pediatric patients, so it's very difficult to evaluate also, but we need to look at mode of injury, the time of presentation. The ocular examination needs to be very well done. So as much as possible, let us try to do a visual acuity and document it, and always document the mode of injury, the alleged history, because all these are legal documents. Examination may have to be done with cuddling, cajoling, or maybe even under anesthesia. And upper and lower lids, maybe you may have to avert, double avert to look for foreign bodies. And we need to look at conjunctiva, sclera, cornea, anterior chamber, iris, pupil. And all these things, if possible, if the patient is on general anesthesia, try to use a handheld slit lamp. Always look for aberrations, lacerations, foreign body or debris, pupillary responses, indirect ophthalmoscopy, and if possible, during the anesthesia itself, get an ultrasound done. Assessing red reflex in the child is moving up and down, right and left. Assessment of ocular motility as well as red reflex is easy. And with a dilated pupil, you can generally go in for a look into the retina. Now let us do some individual cases. Case 1 is a 7-year-old girl with history of trauma with a pen in a school one day back, and the patient presented with somewhere around 6/18 vision. There was a small paracentral thickness, corneal laceration, very small, but AC was very shallow and the iris was almost stuck back to the lens. You can see it's a very small opening, but you can see here that the iris and the lens my iris and the cornea are almost touching each other. The anterior chamber is completely flat. This is a case where you may require to take the patient up for suturing, or may actually do well with a contact lens with glue as well. Whereas this patient was taken up for suturing because the laceration was reasonably big and the wound had to be, the AC had to be formed. So a word of caution here, because there's a very paracentral wound. The senior most and the most skillful person should do the job. The tensile strength, the distance between the center of the wound to either side of the suture, the tightness of the wound, the depth of the wound, all play a very, very important part in astigmatism. This child had 6/6, and if this is a very shortly done job, this patient's vision could be 3/60 as well. So paracentral wounds, be the best, let the best surgeon operate that child so that the best visual recovery is possible. Let's go to another case. This is a 9-year-old boy, history of trauma with metal piece to the left lower lid, visual acuity of 6/6, partial thickness laceration medial to the lower punctum, including the canaliculus. And here we had to do a canalicular repair with lid suturing. I want to say that I don't do these surgeries. My oculoplasty surgeon, Dr. Sujitra, does these surgeries. And this is the patient who came in. There was a wound, left inferior part. You can see that we try to see how thick the wound is, how deep the wound is, and also look at the this is the canaliculus which is getting probed, and we have to look at the other side. Okay, once you probe that particular area, you can see the other area and look for the remaining part of that. And slowly we find that out. And then we have to introduce the Lester-Jones tube and take it out and then put it back there to the other side, so that you know that there is, when we suture it back, the continuity of the tube is maintained. That's very important. That's a step which is very important. Then you suture the deeper tissues first, so that the approximation is proper and there is no tissue pressure. And then once everything is fine, then once the tissue pressure is all gone now, then we can use silk to suture the skin. Here we are using silk. The inner sutures can be used, Vicryl can be used, basically because they are absorbable suture material. So this is after you suture the skin, and that is end of surgery. You can see that the tube is in place at that point of time. Posterior segment manifestations could be non-penetrating, like optic nerve avulsion, commercial retinae, choroidal rupture, retinal detachment, dialysis, macular hole, all those things can occur. And in orbital trauma, especially with a very rapidly moving projectile foreign body like a bullet, we can have a chorioretinitis sclerotinia, in which the whole retina and the choroid may sink down into the orbit. And systemic trauma can sometimes cause Pusher's retinopathy or shaken baby syndrome. Voice planar vitrectomy is a major technique that has been used to manage severely damaged eye. And pediatric vitreoretinal surgery has its own unique set of challenges compared to the adult surgery. The pediatric vitreous is very thick, and the adherence of the pediatric vitreous to the retina is very strong. So inducing a PVD in a child is not as simple as inducing it in an adult. And secondly, the amount of inflammation, then the amount of the pre-retinal proliferation, the fibrovascular as well as the simple fibrous proliferation, the epiretinal proliferation is so bad that traction retinal detachment, all of them can develop later on also. That makes it very complicated. Now here you can see this is a large study again. You can see the 6/36 is the final visual acuity in all cases when patients were presenting with counting fingers. These are open globe injuries, counting fingers improving to 6/36, and closed globe injuries 6/60 improving to 6/36. You can see that fairly about 60% of patients are improving here, 60% improving even in open globe injuries, about 55% in closed globe injuries. You can see that about 25%, about 15 to 20, 30%. This much reduction of visual acuity is also there. As I said, these are all children in whom proliferations can be much worse, and the initial situation may become worse over a period of time. Now, this is a very interesting statistics between scleral buccal vitrectomy for traumatic retinal detachment and vitrectomy for other indications. When you're doing a scleral buccal, that means that the media is fairly reasonably good and the retinal detachment doesn't have much of PVR, and that is how the visual improvement is about 6/24. You had about 65% of patients having visual improvement. Whereas when the retinal detachment, traumatic retinal detachment was caused by trauma, then counting fingers remain counting fingers, even though there was about 35% having some improvement of visual acuity, but generally the prognosis in this condition is a little bad. That is the reason I said is basically because of the heightened complications during surgery and post-operative complications which occur in that stage. If you do vitrectomy for other indications like blood, foreign body, etc., you can see that the visual acuity improves from counting first to 6/18 and almost 100% improvement in visual acuity. So you can see that traumatic retinal detachment in a pediatric age group is a very, very poor prognosis. Now, this is a large study which looked at 89 eyes in which vitrectomy was done. Rupture was seen in 23, penetrating was 28, intraocular foreign body in 20. You can see that anatomical recovery was seen about 52, which is about 60% of people. And silicone oil sustained eyes means that, with silicone oil, they are attached. And if you remove silicone oil, they may detach. So totally about 80% of patients had anatomical success with vitrectomy. And visual acuity, you can see that even those people who presented with good visual acuity better than 6/12 or 20/40, two went into no light perception. That's a very, very significant problem. With very good visual acuity also, people can go down. Now here are patients further, even as the visual acuity, presenting visual acuity drops, you can see the cluttering here with poor visual acuity. But a lot of them get good visual acuity as well. About 50 to 60% of them, they get good visual acuity as well. Now going to another case, case 3, 13-year-old high myopia, had trauma to the retinal, to the right eye while playing football. And within a month of trauma, the patient presented with multiple tears with vitreous hemorrhage. That's basically because it's a high myopia and the liquid vitreous probably caused retinal detachment a little more faster. And that is why this patient came in. And you can see this is the retinal detachment. I am doing a vitrectomy and removing the vitreous. Once you remove the vitreous, I am basically painting the tears so that I don't miss the tears. You can see the number of tears there, 1, 2, 3, 4, 5, like that. How many tears are there? So these are all peripheral tears, basically because when PVD got induced, it rapidly moved in. So I also made a supranasal retinotomy. And because the macula was looking a little suspicious, and here I was having some unresolved traction there, I made a retinotomy there, which is about 3-4 diameters temporal to the fovea. So I completed the vitrectomy, and you can see that I'm doing an air fluid exchange here. We're using a silicone tape onto the supranasal area. Once we complete the air fluid exchange, now the retina is like almost settled. You can see this is the final bit of fluid which I'm removing, temporal retinotomy as well as a supranasal retinotomy. Now what we need to do would be to do laser and silicone oil injection. Once we do the laser, we are using silicone oil now to complete the surgery. This patient we finally end the surgery by measuring the pressure, and this is the final visual acuity 6/24. You can see some traction even now. Case number 4, 18-year-old boy, accidental injury to the eye with a hammering nail. Vision was very poor and full thickness corneal perforation, shallow AC with iris prolapse. Primary repair was done. And after this primary repair, we went in for a corneal transplantation. Dr. Anil does my corneal transplantations. This is a trephining and removal, and we are doing a transplant with good results, 1 week good result. But you can see that after 1 month post-peak, a total bullous retinal detachment. You can see the retinal detachment right in the pupil here. This is the edge of the retinal detachment. That is when we went in. You can see that I cannot enter directly into the vitreous because it is all retina only. I would go subretinal. So I made a port there and introduced an infusion cannula there. And once the infusion cannula is there, you can see the retinal detachment right at the pupil. So I'm trying to massage it back, but it is not going so easily. You can see small tears which are there in the posterior pole itself, and it's prolapsing into the anterior chamber. So subretinal fluid aspiration was used using a silicone tip was tried, but it was not going at all. So finally, I understood that with that pupil, I cannot work. So I was enlarging the pupil. I enlarged the pupil. I could have used hooks, but using hooks would intraoperatively, it will become better. But what will happen post-operatively is that they will again go back to a small pupil. So post-operatively also, we want very good mydriasis. So here, we are again trying to remove subretinal fluid. And once subretinal fluid was removed, I made 3 ports and went inside. This is a point of time where I decided that I will use PFCL. So PFCL was injected there. And you can see that I could see PFCL there, but there was a subretinal PFCL here. You can see the bulla here like a choroidal detachment. And that requires to be removed. We had to make an opening there and slowly remove the PFCL from that particular area. You can see the opening which is created there. And you can suck the PFCL out and you can see the retina coming back. So that is PFCL removal. You complete the vitrectomy. And this is the rest of the PFCL from posterior pole, which is getting removed. Once the retinal mobility is ascertained and the vitreous is completely removed from the retina, Then this particular patient requires again more PFCL injections so that the retina is completely attached. And then under PFCL, we laser all the tears. And once we laser all the tears, I did a direct PFCL silicone oil exchange. So direct PFCL silicone oil exchange, and then further laser, and then completion of surgery. This patient has a 6/36 vision now, that post-penetrating keratoplasty, post-retinal detachment. Thank you very much.